We described the PK/PD properties of antibiotics used for C. diff infection and identified risk factors for the development of new onset and recurrent C. diff infection. We also assessed the clinical presentation and diagnostic laboratory findings to determine if a patient has C. diff infection. Now, given a patient with new onset or recurrent C. diff infection, recommend IDSA guideline-concordant treatment. Let's take a look at the treatment of initial C. diff infection. So these are patients who have new onset incidence of C. diff infection. Non-severe C. diff is defined as those patients who have a white blood cell count of less than 15,000 cells per ml and their serum creatinine is less than 1.5 milligram per deciliter. For these patients, the first line recommendation is either vancomycin 125 milligram PO 4 times a day for 10 days or fidaxomicin 200 milligram PO twice a day for 10 days. These two are very effective for treatment of non-severe C. diff infection and recommended first line. Metronidazole used to be first line too, but starting from 2017 IDSA SHAE guidelines, it is now recommended alternative. In settings where access to vancomycin or fidaxomicin is limited, IDSA suggests using metronidazole for an initial episode of non-severe C. diff infection only. It is important to avoid repeated or prolonged courses of metronidazole due to risk of cumulative and potentially irreversible neurotoxicity. Now, severe cases of C. diff infection are defined as white blood cell greater than or equal to 15,000 cells per ml, or if the serum creatinine in patient is greater than 1.5 milligram per deciliter. For these patients, metronidazole is not recommended. It is recommended to use either vancomycin at lower dose of 125 milligram 4 times a day for 10 days, or fidaxomicin 200 milligram PO twice a day for 10 days. It is worth noticing that fidaxomicin is significantly more expensive than vancomycin. Now, for fulminant cases of C. diff infection, these are patients who have hypotension or shock, or if they have ileus or megacolon. These are complications of C. diff infection. For these severe complicated C. diff infections, vancomycin at higher dose of 500 milligram PO, or if the patient cannot take PO because they're in shock, or if for some reason they cannot take oral, it can also be given through nasogastric tube. Now, this is recommended in combination with metronidazole. So metronidazole 500 milligram IV. Every 8 hours. Now, keep in mind that this is an IV formulation of metronidazole, not oral. And the theory is that when we combine this, if because of the complications of C. diff infection in these patients, oral vancomycin is not going down the GI tract, so it's not getting to the site of infection in the colon. By giving IV metronidazole, there will be some profusion of the GI colon, so metronidazole can actually get a small portion of it can get to the site of infection through the IV route. Now, ileus basically means the lack of movement in the intestine. So if someone does have ileus, the IDSA guideline recommends consider adding rectal instillation of vancomycin, because if you give it through the mouth or nasogastric tube, it's still not going to make it through to the site of infection. So giving it rectally, which would be at the same dose of 500 milligram 4 times a day. Now, it is recommended by IDSA that to discontinue therapy with the inciting antibiotic agents as soon as possible, as this may influence the risk of C. diff infection recurrence. Antibiotic therapy for C. diff infection should be started empirically for situations where a substantial delay in laboratory confirmation is expected, or if the patient has fulminant C. diff infection. Let's take a look at treatment of recurrent C. diff infection. Now, for the first recurrence, the recommendation is based on what the patient received for the first initial therapy. So if the patient received metronidazole, and remember from the PK/PD of metronidazole that because metronidazole orally is 80% bioavailable, we get significantly lower concentration of metronidazole at the site of infection, which basically leads to its inferior efficacy for treatment of C. diff infection compared to vancomycin and fidaxomicin. So it will be common to see patients with recurrence if they receive metronidazole. So if that is indeed what the patient received for the initial therapy, the recommended treatment for this first recurrence is to give vancomycin at lower dose of 125 milligram PO 4 times a day. It is no longer recommended to give metronidazole if the patient received metronidazole for the first initial therapy. Now, if the patient received vancomycin for the first initial therapy and now is having recurrence, it's recommended to use fidaxomicin for 10 days, or if you are to use the oral vancomycin, again, it is recommended to use prolonged taper and pulse vancomycin, which would basically mean 125 milligram 4 times a day for 2 weeks, followed by twice a day for another week, and then daily for another week, and then every 2 to 3 days for a duration of 2 to 8 weeks. And of course, metronidazole is not recommended for these patients. Now, for those patients who have a second or more recurrences, again, fidaxomicin is recommended first line, or we can do the same prolonged taper and pulse vancomycin dosing, or we can do a vancomycin chaser dosing. So we basically do vancomycin lower dose for 10 days, followed by a chaser of rifaximin 400 milligram 3 times a day for 20 days. Now, for these patients, the guidelines also recommend fecal microbiota transplantation, which is a controversial topic. And of course, metronidazole is not recommended for these patients. Now, there are insufficient data to recommend screening for asymptomatic carriage and placing asymptomatic carriers on contact precautions when it comes to prevention of C. diff infection. There are also insufficient data according to the IDSA guidelines to recommend administration of probiotics for primary prevention of C. diff infection outside of clinical trials. So more clinical trials are needed. Now, minimize the frequency and duration of high-risk antibiotic therapy and the number of antibiotic agents prescribed to reduce C. diff infection, because we know that a significant risk factor for C. diff infection is the receipt of antibiotics. And in fact, it is recommended to restrict high-risk antibiotics when possible in hospitals. For example, it is recommended to restrict fluoroquinolones, clindamycin, and cephalosporins, unless cephalosporins are being used for surgical antibiotic prophylaxis, and because those are single doses, it becomes it's really not feasible to restrict cefazolin a single dose for surgical prophylaxis. So outside of surgical prophylaxis, it's recommended to restrict cephalosporins. This concludes this presentation.